Hello, everyone. This is Josh from SIBO Survivor, and tonight I'm joined by Dr. Leonard Weinstock. Really fortunate to be able to sit down and talk to Dr. Weinstock. A little bio about him. So, Dr. Weinstock received his medical training in Rochester, New York, and completed a gastroenterology fellowship at Washington University in St. Louis. He is board certified in internal medicine and gastroenterology. He has a clinical teaching appointment as an associate professor of clinical medicine and surgery at the Washington University School of Medicine. Dr. Weinstock lectures and research have been presented at national and international conferences on diseases of the esophagus, stomach, small intestine, and colon. And he is actively researching the connection between the gut and SIBO with several other medical syndromes and conditions. So I'm excited to just sit down and talk with him about underlying causes in SIBO and maybe what other coexisting conditions someone should be familiar with if they're dealing with these issues. So what's going on, Dr. Weinstock? Happy to have you.
Thank you so much, and I heard you're in Thailand, so
yeah,
it should be interesting. Cool.
Yeah, definitely. So like I said, in this interview, I want to dive kind of into the underlying causes and associated diseases you've seen in SIBO, because I think it's important for people to remember that SIBO is a secondary effect from another malfunction in the body. So I think first, can you kind of just give the listeners an overview of the most common underlying causes that they should at least be aware of, and maybe even bring up to their doctor, right, about why this could be occurring?
Okay, very good. Well, let's step back 1 second and say you could pick up a GI textbook and you could find the chapter in small intestinal bacterial overgrowth syndromes, and you'll find all sorts of things that I'm going to address. But the doctors who actually studied and read that chapter know that irritable bowel syndrome is not included in that chapter. So basically, since 2000, that's where the changes have occurred, where small intestinal bacterial overgrowth has been shown to have a big role in irritable bowel syndrome. But the people who are very black and white in the industry of medicine, even though Suboxone was approved in 2015 for treatment of irritable bowel, just don't get it. So when you say bring this information to your doctor, you're going to have to realize that if they're old school, they're not going to be in tune.
Yeah,
that's a problem. But not all irritable bowel syndrome is SIBO, and yet probably for diarrhea, 60% is due to small intestinal bacterial overgrowth. Okay.
Interesting.
And so, what are the causes of small intestinal bacterial overgrowth in general? Mm-hmm. And what's most common in irritable bowel? Well, let's just jump to the irritable bowel for a second. That 60% of patients with IBS-D have the autoantibody antivinculin.
Yeah.
Now, you've discussed that already?
Yeah, I have, and on my kind of About SIBO page, I kind of go into more detail about that. So, it has to do with the autoimmune issue when someone gets food poisoning, right? So they're infected, yeah. So
that's really critical and big. And in the study where Suboxone was approved, 2,600 patients in that study had blood testing, and 60% had a positive antivinculin test. So large, and this is damaging the migrating motor complex, which allows bacteria to increase in population. So going back to your question, there are basically 4 categories of conditions that lead to SIBO. Number 1, malabsorption. So you'd include pancreatitis and celiac disease in that. Number 2, anatomical disorders. And so post-gastrectomy or blind loops or jejunal diverticulosis or an Ehlers-Danlos syndrome, droopy-loopy loops of the small bowel. Then number 3 would be immune dysfunction, like CLL, IgA deficiency. And then number 4 would be motility disorders due to nerve and muscle disorders. So you have 4 things.
Yeah.
You can't absorb the nutrients, so the bacteria do. You have a anatomical condition that allows for a swamp to occur where the bacteria grow.
Mm-hmm.
Number 3, you don't have immune defenses, so the bacteria cling to the small bowel and stay there. And number 4, you've got a disorder of the motility, so you don't sweep it out.
Gotcha. So, I mean, I guess let's say someone is having these issues and they want to kind of check for these underlying causes. Are there any tests, or is there anything that they can talk to their doctor about to say like, hey, one of those causes I think maybe possibly could be an issue? What does someone do to kind of get into that and figure it out?
Okay.
Yeah.
So let's start from the top.
Yeah.
So malabsorption.
Yeah.
Get yourself tested for celiac disease, or even try a gluten-free diet in case you're the wheat-sensitive type.
Yeah.
Number 2, in that same box, in that first box, get a test for pancreatic insufficiency. Important with chronic, with aging, there's atrophy of the pancreas, or if you have a lot of pancreatitis, that can result. So then you move on to the next box. That's anatomical, so you will think of anatomical conditions. If you had surgeries, and you might have adhesions, or you've had surgery and there might be a blind loop, or you got jejunal diverticulosis, get a small bowel follow through to exclude that.
Yeah.
Number 3, immune, get a blood count. Think about immune disturbances, maybe get immune globulin panel.
Mm-hmm.
And number 4, that gets much more complicated, but the top-notch thing to do is to get, and this can be done first, the Ibs Chek Test, which looks for the antivinculin antibody.
Cool. So is that Ibs Chek Test available now? Because I know in the past it kind of went off and on and.
Well, it was on,
yeah.
Then it went off, and now it's back on.
Yeah.
At Commonwealth.
Awesome. Yeah. So that's a recommended test to see if someone basically, if their SIBO was from food poisoning, basically, right? And they're having that autoimmune motility issue.
Right.
Okay. Gotcha. So awesome. So those are all the things that someone can be aware of and talk to their doctor about to see what maybe is causing this. So I guess next, let's talk a little bit about common coexisting diseases or syndromes that you see with SIBO. So, for example, acne, restless leg, fibromyalgia. Which of these conditions have you seen a lot alongside SIBO?
Oh, absolutely. So, I like the Venn diagram. I don't know if you have ever seen a Venn diagram, but you start with like a disease like this, and then you start overlapping other conditions that are associated with it.
Yeah.
And irritable bowel is one such thing, and what gets me excited are, in fact, these extraintestinal manifestations, which can be caused by a number of different things. But what I see is fatigue, muscle pain, possibly fibromyalgia, which is a wastebasket term, because probably there's no real fibromyalgia. It's certain disease states, such as mast cell activation, that triggers a number. Interstitial cystitis, chronic prostatitis, restless leg syndrome, rosacea. We don't know enough studies about acne, but a lot of people have bad skin in a variety of ways. Eczema, for instance. So those are the top ones that come to mind when I think about conditions that are associated with it. And then, of course, you've got psychological factors, anxiety and depression. But as opposed to most gastroenterologists who think, well, that's what causes irritable bowel, I think it's vice versa.
Cool. Yeah. So that leads me kind of to my next question, right? Is when someone has one of these coexisting conditions, is it usually does it usually happen because of the bacterial overgrowth or the IBS, or is it usually, could it be that coexisting condition that's causing the SIBO, right? Like it's kind of complicated, right?
Well, I think, and I'm doing research on this, that
Yeah,
mast cell activation syndrome damages the autonomic nervous system, and that causes SIBO.
interesting.
And then it also causes muscle inflammation and chronic fatigue and a host of symptoms.
Wow, yeah, that's very interesting.
Including restless, yeah.
Yeah, so basically, what you're saying is a lot of these coexisting conditions could potentially be causing SIBO as well, right? So that's a
And
really
vice versa. So you're
yeah,
right. So, you have to look at where that Venn diagram is, what's causing what. I honestly think, in light of the frequency of mast cell activation, that it's underlying a lot of patients. But let's just take, 60% of the IBS SIBO out of that pie
yeah,
and call it what it is: post-infectious irritable bowel with autoimmune dysfunction.
yeah. Exactly. So basically, for sure, right now, we pretty much know that 60% of IBS is SIBO with that autoimmune from food poisoning. Is that correct?
Correct.
Okay, and then the next 40% is basically could be due to some of these underlying causes potentially, right?
Right. So some of it's going to be SIBO, some is going to be inflammatory IBS.
Yeah.
So even from a post-infectious state, you may not have SIBO, but you may have inflammation causing visceral hypersensitivity. That's where my work in low-dose naltrexone comes in, that there are some patients who just don't get better with anything.
Yeah.
And they're finding relief by reducing inflammation.
Interesting. Really, really cool. So what's kind of the best approach to treating someone who maybe has coexisting conditions? Is it something where you kind of really try and investigate that and see if that may be something that you work on first before doing anything, like antibiotics or anything like that? How do you kind of process that? Yeah.
Well, I think a thorough history is critical. So if you have a strong history, and then you're picking up signs of histamine release with, hives, itching, rash, itchy eyes, runny nose, and then you talk to them about fatigue and muscle pain, nausea, then you're building a story that makes you worried about mast cell activation. So you can't just treat the SIBO that's due to it. You have to treat the mast cell activation. With respect to, the antivinculin, well, we don't have a cure for that at this point. Like, we have treatments, and we have treatments for motility associated with it, but again, it's more than just the antibiotic. You have to treat the chicken and the egg problem and help out heal the gut lining and improve the motility.
Yeah, and I think that's really important just because, I guess a lot of people out there who just hear the term SIBO, right, they just think that they need to just work on only the bacterial issue. But it's important to remember that it's caused by something else. And in the case of 60% of IBS, it's the autoimmune antivinculin. So the nerves aren't functioning correctly, right? So there's a motility issue. So that's a really important piece that people need to get support on, right?
Right.
Yeah.
Right. Yeah. And if you look under the microscope, the cells that are the nerve cells actually go away. So you lose them. But some people get over this. I mean, there's probably 50% of people who get over post-infectious irritable bowel syndrome. The autoantibodies dissipate for whatever reason in time, and then you'll regrow your nerves. So there is hope for some people that they will get better.
Yeah, that's really encouraging. So, I mean, does that take years, or does that take, how long does it take sometimes for someone like that?
All right, so there was a study out of Ontario where they looked at a community that had a big outbreak of food poisoning. 33% of the population got ill, became IBS patients, After 5 years, 50% were better. Now, they didn't look at bacterial overgrowth, so we didn't really know.
Yeah.
But basically, 50% got better, and then conversely, 50% kept on with IBS.
Okay, gotcha. And then one other question on that topic is for the blood tests. Let's say someone orders the blood test. If it comes back positive, definitely they have, IBS, SIBO from that food poisoning event. And then if it comes back negative, does that mean for sure that it wasn't from the antivinculin, or is that test like totally correct? I guess.
Well, it's got phases to it, so there are different levels. It's just like having a lupus test, ANA test.
Yeah.
You have low level tests and you have super high level.
Yeah.
When it's super high, you believe it. When it's super low, you probably say, no, it's not significant. It's just white noise.
Yeah.
But your question is excellent. So the key thing there is when you look at the Ibs Chek Test, it says check, this is IBS, but they're infirming, saying it's cause and effect from the antibody, and then a different spot is checked. If it's negative, saying no, this is not IBS, you need to look further. Well, it could be IBS, but it could be IBS caused by adhesions. So we're finding that adhesions, with and without a history of surgery, can play a big role. And I just published a paper on that, but you will want to keep your mind open. You'll want to start thinking about what other things cause SIBO, let's say because your breath test was positive, or what other things cause IBS.
Gotcha. So if someone has that test and it comes back negative, definitely kind of start thinking about those other underlying causes and what else could be happening, whether it's adhesions or any of the other conditions, right?
Ehlers-Danlos syndrome, 2% of the population have it.
Yeah.
And so they can have loopy-droopy loops of bowel.
Yeah.
Acts like a sunk.
Gotcha. Interesting. So next kind of topic to touch upon here is just a little overview for anyone who doesn't know what mast cell activation syndrome is and what you're seeing as far as the research you're doing and how this may be linked to SIBO.
Okay, very good question.
Yeah.
So it's really exciting. This is something that was first reported in 2008 in the case report, 2011 in 20 patients, and then most recently a case series of 400 patients in 2017. So think about time. That's a baby in terms of intro. And so most physicians don't know about it. More patients than doctors know about it, to be quite honest with you, because of the internet. So that's funny right there.
Yeah.
So with respect to this, you're either born with a mutated mast cell, and I just saw a mother-son combo who lived near a radioactive waste, and she developed mast cell activation syndrome, and he did from birth. So you're either born with it, or you get secondary mast cell from Lyme, from mononucleosis, from a vaccine that basically mutates the mast cell so that when it comes out of the bone marrow to live in your tissues, it's more highly activated and releases chemicals on its own for no good reason. And then you suffer from well over 48 different problems, or have a patient just this week. Irritable bowel, stuffy nose, runny nose, and some painful periods. And that's all she has as her main symptoms of active mast cell disease.
Yeah.
And so, it's a wide range from being terribly affected to having mild disorder.
Gotcha. So is that when someone has mast cell, does SIBO occur with that, or like how does that connection play into it?
So it's one of two ways. The most likely is that the mast cells live next to the autonomic nerves and put you in sympathetic dominance. And when the sympathetic dominance, the small bowel doesn't go into peristalsis. You're not in the parasympathetic rest and digest phase. You're in the fight or flight phase. So you can't relax your sphincters. Your eyes are wide open. Your heart rate goes up with standing. These are the things that occur with sympathetic dominance. And it's because of the mast cells releasing chemicals next to the nerves and making the nerves misfire. So if the small bowel is slow, you're going to have bacterial overgrowth.
Yeah.
Potential.
Gotcha.
And so that's what I'm finding. And I'm just doing a study now of 150 patients, but I'm finding the breath test to be abnormal in 46% so far.
Really interesting. So that, pretty much just means that really anything that slows down the bowel or affects the function, right, has a potential to cause SIBO. Is that correct?
Correct.
Yeah. Cool. So next, can you kind of another condition that's being talked about, and I know that you're kind of researching as well, is postural orthostatic tachycardia syndrome.
Right.
So yeah, what is that?
So POTS was first reported in 1993. Once again, all the articles on POTS are basically in the cardiology and neurology literature, so your doctor doesn't know about POTS.
Yeah.
He knows about orthostatic hypotension, but basically this is orthostatic intolerance. So what happens is, if you've got this condition, you stand up, your heart rate goes up like above 30 from lying to standing, even more so in the morning. And then you get sympathetic dominance with the things that I talked about. Your pupils are open, it's hard to accommodate to light, your mouth may be dry, your urine is hard to pass, and because of the sphincter increases tonicity. Likewise with the rectum, people with bad rectal tightening, so-called sphincter spasm, many have POTS. So POTS can be caused by mast cell activation, as I said. It can be caused by autoimmune disorders, and it can be caused by random things like Lyme disease, Gardasil vaccine, trauma to the brain, post-concussive state. So those are the known things that can cause it. EBV vaccine too.
Yeah, really interesting.
That virus, pardon me.
Yeah, and so, that kind of just shows how it just seems like IBS, gut issues in general are just really kind of linked to so many other things in the body, right? If something else is happening, then they could potentially cause an issue in the gut or irritable bowel and whatnot, yeah.
So the thing is that I always emphasize is that IBS, a syndrome, is basically a description of symptoms with multiple causes that are not well defined. Well, I think we're going into a golden age for IBS because we're going to identify all these things, and then we'll only be left with a handful of patients who have idiopathic irritable bowel syndrome.
Yeah.
Everybody will have irritable bowel disease or irritable bowel symptoms due to X, Y, or Z.
So
that's the exciting part.
That's really exciting, especially for me as a patient when, like a lot of people out there, right, who have IBS and SIBO and kind of this, are kind of put into this category, right? And it's still like kind of very uncertain, and we're not really sure exactly sometimes what's causing it for people. So for me as a patient and for a lot of people even watching this, I think it's exciting, and I think, it'd be awesome if we get to the point where, we can actually identify that underlying cause, right? Like all the time.
You're so right.
Yeah.
So right.
So lastly, the connection between a couple more things, restless leg syndrome and chronic fatigue. So I actually have had personal experience kind of with both of these, with the IBS, SIBO, and then restless leg and fatigue, right? And I think a lot of people, you've probably seen a lot of patients who also have these coexisting conditions going on as well, right? So what is kind of the connection here between these?
Inflammation.
Inflammation.
Inflammation. In an overview, in one word. But that inflammation can come from many, many different things, ranging from mast cell disease to gut disturbance, change in microbiome. It really can be so many different things. If you look at mast cell disease, between 1 and 17% of the population have it. And the two most common symptoms of it are fatigue and muscle pain. Well, if I said that to any doctor or any layperson, they'll say, "Oh, that's fibromyalgia." Well, yeah, it is. But if it's got a known cause, it's not really fibromyalgia syndrome. It's pain and fatigue due to something else, in this case, mast cell. So, but then again, on the other hand, when you've got bad SIBO, you've got disruption of your tight junctions in the gut lining. You have activation of lymphocytes and mast cells and creation of cytokines which circulate, go to the brain, upset the HPA axis, hypothalamic pituitary adrenal axis, which causes fatigue. So that alone in SIBO plays a big role.
Interesting. And it's kind of like, once you someone gets into that cycle, right, of, this disrupted gut and maybe the microbiome change that, it's kind of like things just start it's a ladder or a domino effect, right, where other things start to occur. Is that kind of true?
There's a vicious cycle that goes on.
Definitely.
And because SIBO actually stimulates mast cells to be active and degranulate, again, it's a vicious cycle. And even if you didn't have the whole syndrome and you were dealing just with inflammatory cells locally and this bacterial overgrowth, there's stimulation of the lymphocytes and mast cells locally causing trouble. So people who have histamine intolerance, they may, in diet foods, they may not have histamine intolerance because of mast cell activation syndrome, but just locally they could have problems.
Gotcha. Awesome. So I guess the last thing is just like anyone who has maybe a recurring or tough case. So you'd probably, what would you advise them? Basically to look, when they're going to their doctor, right, to kind of be educated on maybe some underlying causes and, really try and look into that first. What would kind of be your advice there if someone's having recurring issues and they can't figure it out, right? Maybe.
So I do find, Josh, the breath test to be helpful. Give an assessment of how bad their condition is and to confirm it. So if I treat with rifaximin, for instance, and they don't get better, that's a perfect time to do a breath test. Although that said, I often do it first to see how high the numbers are to get some feeling. A, am I correct? And B, are they high risk of relapsing because of high numbers? Also, do they have methane and need more than one antibiotic? So that's a little bit of an answer. Go ahead.
So in that, let's say, they do a blood test, that test comes back and it shows they have, post-infectious IBS with the autoimmune component. Do you usually, recommend a prokinetic in that situation?
Absolutely. Well, I do. Especially you get history from them. They've had it for 10 years. One course of antibiotic, they're going to have relapses. Their numbers are high, that's bad. They have associated condition, that's bad. And I also will use low-dose naltrexone. So naltrexone increases endorphins, which modulate inflammatory responses and may reduce the antibody levels themselves. That hasn't been studied, however.
Okay, cool. So that's another good medicine, right, that someone should at least be aware of that could potentially help them, low-dose naltrexone.
Right, and I have a lot of information and lectures I've given on that on my website, gidoctor.net.
Awesome. Well, so I guess you just said it, but where can the audience find you to kind of maybe, if they want to learn more about your research or, maybe get in contact or something like that? What's your website one more time?
GIDoctor.net.
Awesome.
And so, yeah, so that would be a way to learn and educate your own doctor and actually arm yourself. So you come in and, you see your gastroenterologist and say, hey, I've done reading about small intestinal bacterial overgrowth. I want that IBS Chek test.
Yeah.
Because I want a diagnosis, and I want, if it's negative, I want you to explore other avenues with me on my behalf. And hopefully you'll have an open-minded doctor, or if you don't, move on.
Yeah. And that's such a good piece of advice because, at the end of the day, we're just trying to figure out what's going on, right? And whatever we can do to figure out, maybe even if it's from food poisoning, if it's not, that allows us to maybe start looking for these other causes that we've talked about, the coexisting conditions, and kind of just really dive more into it. It kind of gives us a good baseline. So awesome, and I think that's going to be super helpful for my listeners. Really appreciate you taking the time to come on and chat tonight.
Thank you so much.
All right, thanks so much.
You as well.
Yeah.